Next, I want to invite Meg Smith. Dr. Smith is a graduating fellow from the University of Michigan. She is a Michigander. She played collegiate soccer and went to University of Michigan for medical school and stayed on for general surgery and vascular fellowship. And she is currently on the job search. And so everyone keep your eyes open. So Dr. Smith's going to be presenting on acute limb ischemia.
There we go. Thank you. Sorry, I was having trouble with my microphone. Thanks for letting me present. I'll be talking about some acute limb ischemia data that we looked at within the state. So it's no surprise to any of us that acute limb ischemia is a big problem. And just kind of put it in reference. A really good paper a few years ago looking at the Medicare beneficiaries. So obviously just an older population. While we saw decreasing rates of this nationally, we still were seeing about 26 cases per 100,000. And 75% of those were undergoing some sort of limb salvage operation, when about 50% in 2009 were open. So something that we're seeing a lot. And the morbidity and mortality associated with this hasn't really improved that much over the years and is still high. So anywhere from a in-hospital amputation rate 30-day of 7% to up to 11% at 1 year. And it's kind of pounded in our heads from an early age that time is tissue. And Dr. Rasmussen's group just looked at this again within a military population, so slightly younger patients, but saw that kind of 6-hour mark may be somewhat misleading. And so when they looked at military trauma casualties and they looked at that 6-hour mark, if they had ischemia kind of at that point or longer, still about 50% were losing their limb. When they looked at that and broke it down by patients that were in shock or not, likely hemorrhagic from the injury mechanism, they saw that for patients that weren't in shock, still only about 70% at that 30% at that 6-hour mark were losing their limb. And again, kind of to further elucidate this, if you had ischemia more than 6 hours before a surgical revascularization, an overwhelmingly large percentage of them were ultimately losing their leg. And so within their data, or within their population, every 60-minute delay to revascularization, really starting at the time of injury, resulted in a 10% reduction in the chance of successful limb salvage. And again, this isn't 100% representative of our patients. These are mostly young, kind of healthy individuals, but I think it just highlights the fact that this is a big problem, number-wise, but also that this time is tissue, and that 6-hour mark is something that we've learned, but may not be super representative of real-world data. And so we quickly wanted to look at the impact of both patient factors within our database and procedural timing on both early and long-term or 1-year outcomes following open thrombectomy. And so this was patients that underwent an open thrombectomy for acute limb ischemia that was identified kind of by the surgeon or coder. And we specifically looked at open thrombectomy just to kind of decrease heterogeneity among endovascular revascularization procedures. And they also had to have complete discharge information. For this, we looked at baseline characteristics, time from symptom onset, although that was somewhat limited in the database. And so really we looked at hospital arrival to intervention, and then looked at unadjusted and adjusted rates of morbidity and mortality, both at 30 days and 1 year. And finally looked at that as a composite outcome. So amputation or mortality at the 2 time points. So overall, we had about 954 individual patients that were, I think, representative of what we imagined. So somewhat older population, about 50% were male in the state, 80% were white, and BMI of kind of normal to obese, and had the comorbidities that you would expect. Little under half were current smoker, with, if you include that with former smoking, almost 2/3 of the patient population. A large portion of patients had hypertension, hyperlipidemia. 30% were had a diagnosis of AFib coming into the hospital, or diabetes, and a small proportion with renal failure. The medications of patients, and this will become important just to think about later on in the results, but about 50% were on our standard kind of cardiovascular meds, so 50% on an aspirin or a beta blocker or a statin. And coming in, these were medications at the time of admission. 18% were on a DOAC and 9% were on Coumadin. We looked at time to intervention, and kind of if you take a kind of 10,000 foot view, I think overall, the majority of patients had intervention within an early period. And this is time from arrival to time to arrival at the hospital to surgical incision at the hospital where they underwent surgery. So it doesn't take into account a symptom timeline or if the patients were transferred. And I don't have it here, but when we kind of a more granular look though, in this first bar where you're like, oh, we're doing pretty well. When we looked at those 900 patients, only about a third of them had their surgical revascularization start within 6 hours. So it was about 320 patients out of the 950 were in the operating room within 6 hours of arrival at their hospital. Patients that at discharge, when we start looking at outcomes, a few kind of increased the number that were on aspirin, beta blockers, or a statin. And within the state, the majority of these patients that weren't coming in on anticoagulation, a larger proportion we were initiating on DOACs, with nearly 50% of the population going out on a DOAC, and 17% of the patients ending up on Coumadin. When we looked at 30-day and 1-year outcomes, I think it still continues to show that within our state, this is kind of overall for patients that underwent any time, just regardless of the time, that morbidity and mortality is still high. So at 30 days, 9% of patients had an amputation, and that goes up to 20% at 1 year, with about a quarter of the patients dying within the first year. And when we looked at that as a composite outcome, which I think really is important just in terms of how sick our patients are, but ultimately kind of two outcomes that really impact patients' lives, nearly 20% were having an amputation or dying within the first 30 days. And that went up to almost 40% at a year. We then wanted to look a little more granular, and so looked at patient factors and procedural timing. And I'll kind of skip through the 30 days because I think that, not surprising, the 30-day outcomes are probably more related to things that we didn't capture. So how long the patient or how sick the patients were at baseline, and something that even with comorbidities we can't capture. We really just saw that for 30-day morbidity and 30-day mortality, a background or a pre-existing condition of congestive heart failure was important. But when we start looking at the 1-year data, we see, not surprising, for 1-year amputation, being a former smoker or a current smoker, we had an increased odds ratio of having an amputation at that 1-year mark. And this is where we start to see that timing really kind of impact. And so when we looked at logged hours from arrival, just given our distribution, we see that in addition to smoking, the longer it was from arrival to the hospital to surgery, even though we didn't see that come out at the 30-day amputation timeline, that at 1 year we did see that start to have an impact. Similarly, when we look at 1-year mortality, age, I don't think is surprising as an important factor, with male gender being protective. Congestive heart failure and pre-op creatinine were independent factors and give you a higher risk of mortality at 1 year, probably just demonstrating an overall kind of sicker population. And interestingly, we start to see that again, time from arrival to incision increased 1-year mortality. And then we also start to see that patients that were on DOACs preoperatively had a higher odds ratio of 1-year mortality. And those two things carried through when we looked at a composite outcome, so amputation or mortality at 30 days, where, being on a DOAC preoperatively or pre kind of acute limb ischemia episode was a risk factor for having a 30-day composite, as well as the longer it took to go to the operating room, the more likely patients were to have either amputation or mortality. And that's also carried through at the 1-year mark. So a DOAC, an independent risk factor, as well as time to incision. And so I think overall, when you think about kind of how we're doing, it's not surprising that acute limb ischemia that underwent surgical thrombectomy is associated with significant morbidity and mortality. And these patients have a lot of comorbidities, and so it's hard to tease out 100% what the direct correlation of that. But I do think it's interesting to see that even kind of in modern day and within our state, that risk of amputation mortality is extending beyond just that short-term 30-day period and persisting 1 year after follow-up. within the state, again, only about a third of patients, once they got to their kind of ultimate hospital or treatment hospital, were in the operating room for an open thrombectomy within 6 hours of their admission. And so I think additional work to kind of identify some modifiable with patient and procedural factors is necessary, and we're planning on looking at that. There's obviously some limitations with this. We don't have all the granular procedural factors, just that there was an open surgical thrombectomy. We don't know things such as when the patient developed symptoms. We have some of that, but not for everyone. And so since it's incomplete, it's a little hard to tease out. And we also don't know things like exactly what stage. So we're, what Rutherford ischemia, were they 2A, 2B, 3, and if any additional like preoperative workup was indicated. So did these, what did it take so long? I also think the next step is to start to do a little bit deeper dive into the patients that had that were revascularized within that kind of first couple hour window versus a little bit later, to start to see kind of how that time to surgery is really playing out in our patients. And so I think that, like I said, we'll gather a little bit more clinical data that we can, but also start to tease out some of the systems issues, such as what barriers to care, which of these patients required transfer. And then I also think the next step would be to see if we're seeing similar findings in patients that are undergoing endovascular suction thrombectomy procedures, since that is kind of a growing shift within our practice. And I don't know that I even have a great explanation for why DOACs, but not warfarin, portended an increased risk of amputation and mortality. But I do think there's probably, it represents a kind of clinical factors that we're not capturing in the database just by comorbidities, but also perhaps reflecting of kind of why they're having acute limb ischemia. And it'll be interesting to see if that kind of continues in the endovascular group. And, I think while DOACs are obviously from a patient standpoint a lot easier, that there's been kind of high adoption of that within a lot of different vascular groups without kind of really clear specific data demonstrating outside of the AFib population. And so it'll be interesting to see as we kind of dig into those mechanisms a bit more. Thank you.
Thank you, Dr. Smith.